friends. Today our guest speaker is Dr. Aurav Vishwabandya from Canada. He will be lecturing on platelet transfusion facts and myths. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS and managed by Mice Ideas. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Rajesh, Mr. Kalpesh and their team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, our guest speaker this evening, Dr. Aurav Vishwabandya from Toronto, Canada. All our discussants who are themselves eminent hematologists, hematopathologists, or transfusion medicine specialists. And you participants for sparing your Saturday evening. Just to give you a view of what's going to be there in the field of academics through Mumbai Hematology Group for next 8 days. Tomorrow morning, there is Sunday, 17th October, 11:30. We have the talk on myelofibrosis from Professor Barbui from Italy. From Monday to Friday, every day in the evening, 6:30 to 9:30, we have got a review of all the advances that have occurred in the field of hematology during the year 2021. So this is 3 hours program for 5 days with about 70 faculty. And it will be wonderful for the postgraduates because they will get a first-hand information on what are the advances published or presented in the field of hematology in the last 10 months. Next Saturday evening, 7 o'clock, we have a talk on hereditary hemorrhagic telangiectasia. For the first time, I think we've never had a talk on this subject from Dr. Al Samkari from Boston, US, who has a very large, probably the largest center on HST in the world. And Sunday morning at 11:30, we have hematology from Singapore, where our colleagues from Singapore, Dr. Bhattacharya Rajat, Dr. Prasad Iyer, and Dr. Joyce Lam Ching Mi are going to speak to us on pediatric hematology, including pediatric AML, pediatric transplants, and hemophilia care. So take out some time and attend this whole week of academics. Our discussions today include galaxy of stars virtually. We've got people from Mumbai, Delhi, Bhopal, Lucknow, Kolkata, Ahmedabad, Pune, Srinagar, Bikaner, Guwahati, and Bangalore. It is my pleasure to introduce each one of them to you. Dr. Manisha Srivastava, I'm honored by your participation. She's medical superintendent and transfusion specialist from AIIMS, Bhopal. Dr. Anand Deshpande, who is consultant transfusion medicine and hematology at PD Hinduja Hospital, Mumbai. Dr. Rajesh Sawant, who is consultant in Department of Transfusion Medicine at KD Ambani Hospital, Delhi, Mumbai. Dr. Aleem Jan, who is hematologist and hemato-oncologist at Mubarak Group of Hospitals, Srinagar. Dr. Dharma Chaudhary, Senior Director and HOD, Center for Bone Marrow Transplant at BLK Super Specialty Hospital, Delhi. Dr. Tufan Dolai, Professor and Head Department of Hematology from NRS Medical College and Hospital, Kolkata. Dr. Pankaj Rentia, who is Clinical Hematologist, Assistant Professor, Department of Hematology and Medical Oncology at Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Akanksha Garg, Assistant Professor, Department of Medical Oncology and Bone Marrow Transplantation from Gujarat Cancer Research Institute, Ahmedabad. Dr. Gopinathan, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Deepankar Bhattacharya, Associate Consultant Medical Oncology Hematology from Vedanta Hospital, Lucknow. Dr. Asif Iqbal, Assistant Professor, DMG Adult Hematolymphoid, Department of Medical Oncology at Dr. Bhubaneswar Barua Cancer Institute, Guwahati, Assam. Dr. Tushar Sehgal, Fellow in Hematology, Assistant Professor of Lab Medicine, All India Institute of Medical Sciences, New Delhi. Dr. Tejaswini Gudibande from Majumdar Shah Medical Center, Narayan Hriday City, Bangalore. Dr. Rajat Jain from Department of Hematology, Sahyadri Super Specialty Hospital, Pune. And now it's my pleasure to introduce our guest speaker for the day. He doesn't require any introduction. He's our own person, moved to Canada. He has been our speaker in the past. He was physically here to give wonderful talks. I remember in ITC Hotel on aplastic anemia and bone marrow transplantation. Subsequently, we have had webinars with him, and today he is back with us. Is medical director, quality of BMT and immune effector cell program at Princess Margaret Cancer Center, Toronto, Canada. Because of his special interest in quality and patient safety, he is currently doing a master's course at Harvard Medical School, Boston. He is Associate Professor, Department of Medicine, University of Toronto at Ontario, Canada. He did his special hematology training from CMC Velo. He was an academic staff at CMC Velo for 10 years before he moved to the Princess Margaret. He did 3-year fellowship in malignant hematology and stem cell transplantation at Princess Margaret. He has published over 200 peer-reviewed journal articles and multiple book chapters to his credit. His areas of interest are graft versus host disease prophylaxis, synallogenic bone marrow transplantation, and haploidentical stem cell transplantation. It's a pleasure to invite him to deliver his talk on platelet transfusion, facts and myths. Thank you so much. And over to Dr. Aurav, please.
Thank you very much, sir. This is always a pleasure to talk. And when Dr. Agarwal is there, he keeps stimulating you. So it is not that it is only a talk, and we all learn so much when we review any topic. So before that, just to ask, am I audible or are my slides visible clearly?
Everything visible, audible. Go ahead.
Thank you. Thank you very much. So what I will talk today is about the platelet transfusion, facts and myths. Few things before that. When I look at my disclosure, I have nothing to disclose. When I look at relation to this presentation, I'm not going to talk on the vaccine-induced immune thrombocytopenia and thrombosis. That is a different topic, which as such will take about 1 hour only to see why it happens, how to manage. Still, there is, even if there are guidelines, all are not based on very strong evidence. So I'm not going to talk on that. Third most important thing, I do not consider myself an expert in this field. We all are learners. I learned even some new thing when I was looking at this topic. So it is always important to have a bidirectional discussion, and I'm happy to see the panelists all are eminent hematologists. One more disclosure, probably after looking at the panel, what I can say is that few of the slides I may go a little bit faster so that I'm not taking most of the time. We can have some time for the discussion. I'll try to probably do it in about 50-55 minutes, try to maintain that, but let us see how it goes. But few slides, knowingly, I will skip just to give some time for discussion. So 2 slides on the introduction on this topic. When we're talking of a platelets and platelet transfusion, what exactly is meant? It is not always said that, okay, if someone has given me a platelet bag and all platelets are same or all have been produced in the same way. So when we take a blood bag and we give it a soft spin, then the platelets are getting formed. We call it as a platelet, which is getting formed from the whole blood rather than the buffy coat platelet. So a whole blood platelet and the buffy coat, the initial change happens rather than giving a soft spin. We give it a hard spin. We take the buffy coat, 4 platelets are pulled, and those pulled platelets, they undergo leukoreduction, and then we call it as a buffy coat. There is a good article published in Lancet. If you all can have, particularly the fellows or the residents who are in the audience, it is a good overview how the platelets are formed, what is the difference between a whole blood or a buffy coat platelets, how it is prepared. I think I just borrowed this diagram from there, but it is a good thing to look at that article, which will give some idea how and what differences are there. And thirdly is through the apheresis. We can collect the platelet from apheresis. The number of platelets in the bags differ. How much dose is adequate? How much dose is inadequate? What will be the ideal dose? We will see it in subsequent slide. And mostly, I think in most centers, the platelets are undergoing a leukoreduction. And I believe most of the centers in India also must be doing that. And what are the advantages of that? We can see it in subsequent slide. The second point, what I want to say is that when we look at the bleeding score, it is important to remember that the bleeding score WHO has defined, which is a grade 1 to grade 4. Why I have highlighted the grade 2, because whenever there is any published article or any comparison, or if someone is planning to do a trial on different drugs or a platelet transfusion, how it is effective, how much it is not effective, everyone takes the grade 2 bleeding, just as a general statement. And the grade 2 bleeding is the clinical significant bleeding, like a hematemesis, melena, profuse epistaxis, petechic and purpura, which are diffuse visible blood in the urine, abnormal bleeding with the procedure site, retinal hemorrhages, bleeding into the cavity fluid. All this will come into the grade 2 bleeding. So why it is important to remember, because if there are two trials or there are any intervention, we cannot look at a grade 2 bleeding of one trial versus a grade 4 bleeding of a other trial. It has to be comparable. And that is the general statement before I start proper to say that it is important to remember what is grade 2 bleeding and why it is important whenever we are comparing across the trial or different intervention. So a few myths about platelet transfusion. I'll touch upon these things when I go through the slides. Few myths: in patients with immune thrombocytopenia, platelet transfusion is absolutely contraindicated. And when I'm talking of this includes ITP, this includes TTP, this includes heparin-induced thrombocytopenia. More platelets is always better. We all know that more is better. So is it always? Platelet transfusion threshold should always be more than 20,000. We should keep on transfusing platelets when it is more than 20,000 because the likelihood of bleeding is more. Patients who have got an IC bleed while on antiplatelet drug should first receive or always receive platelet transfusion. I realized it, and then I'll show you one slide that why a platelet transfusion is not necessary. Then probably a lot of us or most of us do is the pre-medication. Pre-medication is very effective in preventing platelet transfusion reaction. We will see some slides how is it really effective. Patients should always receive ABO and RH compatible platelet. Is it practically possible? Or even if it is practically possible in some blood bank, suppose a fantastic world-renowned blood bank, is it always necessary? We'll see that in subsequent slide. And lastly, all invasive procedures need platelets to be more than 20,000. How true it is. So few of these things will answer in subsequent lesson or talk. So the objectives of my talk, the discussion point, I put it into 5 categories. One is the platelet transfusion, and among platelet transfusion category, I'll talk about a pre-transfusion level, dose of platelet transfusion, and whether we need to transfuse prophylactic versus therapeutic. Second aspect, we'll look at ABO and the RH compatibility. Third one is the role of pre-medication. Fourth, few slides on platelet refractoriness, because when we are talking about transfusion, we need to understand what platelet refractoriness is. And I will touch upon some recommendation or the guidelines which are there, but that depends on how much time we have. Otherwise, that part I may go a little bit faster, depending on how things or how we are moving. So when we look at it, this is from the US, 12 the centers in US, where we'll say that probably is that guidelines are very appropriately followed, and they have, money is not a problem. Everyone will follow the evidence-based guideline. So this is an analysis which got just published last year from 12 US hospitals. Just tell you that it is not that all hospitals are academic centers, but they took about quite a bit of inpatients and outpatient. The total number of patients received about 160,000 platelets. Only 50% of the platelet transfusions were ABO identical. 60% of a platelet transfusion given to RH negative patients, which are RH positive. Look at the common pre-transfusion platelet count. For inpatient, it varies from 20,000 to 50,000. For outpatient, it's 10 to 20,000. Among ICU patients, 35% of the patient received when the platelet count was more than 50,000. The median post-transfusion increment that varied, but it varied from 12,000 to 20,000 for inpatient and 17,000 to 27,000 for outpatient. What it tells us? It just tells us that even if we all are aware that how the platelets will be transfused, we have multiple guidelines. We have the best centers producing a lot of platelets, so production is not an issue. Issuing is not an issue. Still, there is no consistency. So, why it is not consistent? Is it the educational problem among all practitioners, or it is the whims and fancy, or it is the myths which are existing? But this is the practical data which is just published about a year back, means it is still relevant today how we are addressing it. So in a platelet transfusion, let us look at prophylactic dose or transfusion threshold, dose of platelet transfusion, and prophylactic versus therapeutic. The first question comes is that why platelets are necessary. So this is a slide or a cartoon which got published in NEJM, and this one is in the blood, showing excellently how the endothelial cells and platelets cross talk, and how the platelets count or platelets help in maintaining the integrity of the endothelial cells. And this one shows a photomicrograph of the importance of the platelets and neutrophil whenever there is an injury, whenever there is an inflammation in the endothelium, how platelets come to play to maintain that the endothelial integrity is maintained, the bleeding is not that much. So these two cartoons show us that platelets are necessary. Even if someone is not bleeding, platelets are necessary to maintain the integrity. All the time we know that there some micro injury happens throughout our blood vessel. To prevent that micro injury, to see that that micro injury is not causing any bleeding, platelets are necessary. So if platelets are necessary, what should be the platelet count? We know that the blood vessels are so huge in our body. So in that case, is that a very high dose of a platelet count is required? This one was looked at almost in 1985. And at that time, the biologic basis was that the radiolabeled platelet transfusion study was done. And it showed that to maintain an endothelial integrity, we need 7,000 platelet count per day, or the platelet number should be 7,000, which is not a difficult thing for the body to produce. Body produces billions of platelets, and billions of platelets get destroyed, but 7,000 is the minimum number. So that gives the basis that if a 7,000 platelet count is necessary to maintain the endothelial integrity, is it really necessary to keep on transfusing prophylactic platelets to all? For decades, the threshold was 20,000 was used because everyone thought that if we are transfusing something with a less than 20,000, then the chance of bleeding is more. But subsequently, 4 randomized trial, which showed that the safety of a lower threshold is that 20,000 can be reduced to 10,000. And that is even applicable in both auto and allo transplant. I really like this diagram. So on the left side, it shows days of hemorrhage. Here it shows the stool blood loss. And here it shows days with a bleeding of a grade 2 and higher. All three diagrams consistently tells us that the likelihood of a bleeding is more when the platelet count is less than 5,000 or less than 7,000 if you put it between 5 to 10,000. Same thing with a stool blood volume, same thing with a grade 2 bleeding. But as long as or as soon we see the platelet count goes more than 10,000, the bleeding significantly goes down. The days of bleeding significantly goes down, and that remains almost constant up to the platelet count of 80,000. So what does it say? That there is no difference between a 10,000 platelet count and 80,000 platelet count. Only the threshold goes down, or a grade 2 bleeding goes down with a less than when it is more than 80,000, but between 10 to 80 it is constant, and less than 10 the bleeding is more, duration of bleeding is more, blood loss in the stool is more. So this scientifically tells us that a threshold of a 10,000 may be good enough, and this 4 randomized trial looked at it, 10 versus 20, excepting the last trial which looked at a 10 versus 30, and there was no significant bleeding in both groups whenever we compare between a 10,000 versus 20,000. So that is a proof of principle, not only from a radio-labeled study, not only from a randomized trial, also from looking at a clinical data, there is no difference between less than or 10,000 versus 20,000 to say that, okay, more transfusion will actually control the bleeding. And this one, as I showed you this diagram, this is the platelet dosing of one of the most reputed study. Multiple part of these studies have been published in NEJM and Blood, saying that this is the platelet dosing study, which subsequently put it as the platelet threshold should be kept at 10,000 or less than that. Because when the question may come, why not 5,000? So between 5 to 10,000, there was not much significant difference, but not really, because in this study, the people who are having a less than 5,000, they have a 25% chance of a bleeding, whereas 17% when it is a more than 5,000. So that is the reason that why a 10,000 was considered. It is appropriate in patients who are non-febrile, stable patient, and because the bleeding parameter remains almost stable over the range, and less than 10,000, the likelihood of a bleeding is more. But it is not always a number. One has to look at individualized approach. One has to look at a clinical scenario where the patient is getting treated, because there are other factors which may affect the platelet count. Fever, sepsis, infection, anticoagulant therapy, GVST, BOD. Why I have put an asterisk over the high fever here? Because that is debatable. The requirement of a more platelet transfusion in high fever was in the era when people were using aspirin to control the fever. But currently, nobody uses the aspirin to control the fever alone. So is it really necessary to use the platelet transfusion with a high fever? That is not standardized. In my institution, we never give platelet transfusion if someone has got high fever. We keep the threshold at 10 and we maintain that one as 10 unless someone is bleeding. Even if that person has got fever, we do not transfuse platelet. So if we know first thing is that is the transfer, that is the threshold of a platelet count, what should be the platelet dose? So this one was the trial which was published in 2009, almost more than 10 years back, what is called as the STOP trial. So what they did is that they took a platelet, which is a standard dose of a platelet, which is a 300 to 600 into 10 to the power 9, which in the current era is changing, or low dose, 150 to 300 into 10 to the power 9 platelet per platelet bag, and they randomized. So when they compared between a standard dose and the low dose, this DSMB, or a data safety monitoring board, stopped this trial, even if it got subsequently published in Blood. And the reason for stopping that is that in a low dose platelet transfusion, the likelihood or the number of patients who had a grade 4 bleeding, grade 4 bleeding is life-threatening and including intracranial bleed, that one is significant in comparison to the standard dose arm. Even if there was no other parameters which are significant, only as one parameter at a grade 4 bleeding was significant, so this trial was stopped. And then everyone thought that going to the standard dose of a platelet count is good. And they have defined standard dose as 300 into 600 into 10 to the power 9, which tells us that it is 3 to 6 into 10 to the power 11 platelets per bag. Is it still relevant in today's scenario? Again, this group, that is the Plado group, they looked at and they published this one in NEJM subsequently. They looked at the data to say that from the time moving forward, or when we look at in the past, the platelet pool from 10 whole platelet has come down to 4 units of platelet. So can we exactly know that how much platelet dose will be adequate? So this is a randomized trial taking more than 1,000 patients. They divided patients into 3 groups: low dose, medium dose, and the high dose. Low dose is 1.1 into 10 to the power 11 platelet per meter square. Medium is 2.2 into 10 to the power 11, and high dose is 4.4 into 10 to the power 11. Just to compare that, if you say if medium dose is considered as the 1 unit of apheresis platelet, low dose is one half of that, high dose is double of that. So just to give an conceptually how much will be the platelet dose and what is the outcome. If looking at a STOP trial, then probably everyone will say that because here the platelet threshold was 3 into 6 into 10 to the power 11, then the high dose should always be good enough. But if I can show you this one before going to this next slide, there was no difference between platelets when the transfusion was done, either 1.1 into 10 to the power 11 versus 4.4 into 10 to the power 11. And this support the safety of a low dose platelet strategy for prophylactic platelet transfusion for all adult and pediatric. Why pediatric? Because they sub-analyzed this group, which is almost having a 200 pediatric patients, and showed that there is no difference in outcome between a pediatric or pediatric patient when we look at low, medium, or a high dose of a platelet count. Sometimes patients, the higher dose, is there an advantage? Yes, there is advantage, so that the interplatelet transfusion will be, or a duration will be longer. But that one may consider if the practically feasible is an outpatient setting rather than the inpatient setting, because giving more is not always helpful, because we see that if a grade 2 bleeding or a WHO grade 2 bleeding is similar in 3 arms, is it really necessary to keep on transfusing more platelet? And this one was answered by the randomized phase 3 randomized trial. Third thing comes as, if we know, okay, from the numbers wise, it is less than 10. From the platelet, the threshold platelet transfusion is less than 10. Number of platelet count low is good enough as high. Third thing, can we just modify it a little bit and we can only transfuse when there is a bleeding rather than giving any prophylaxis? There have been small randomized trials in the past, and they gave a conflicting report showing that there was no difference, either we give a prophylactic or therapeutic. So in the recent era, 2 trials looked at it, particularly in the area where we all will be interested, the patients who have got leukemias or a transplant or lymphomas or hematological malignancy. The first trial is including patients with a transplant, mainly the auto transplant patient, which showed that when we look at a prophylactic versus therapeutic, the prophylactic is superior in comparison to therapeutic because the number of bleeding in therapeutic group was higher in comparison to the prophylactic group. Then there was a non-inferiority trial, which showed that the patients who received the platelet transfusion in a therapeutic group, means you are transfusing only when there is a bleeding, then the number of bleeding was 42% versus the prophylactic group was 19%. Grade 4 bleeding, which includes CNS bleed, occurred in 5% in the therapeutic group versus 1% in the prophylactic group. So then this one tells us that no, at present prophylactic in a group of patients like a hematological malignancy, in a transplant, prophylactic is superior to therapeutic. And because the likelihood of a bleed related to the therapeutic arm is higher, likelihood of a grade 4 bleeding is higher, so we should be a little bit concerned about that. What is interesting to look at, when they sub-analyzed this, there was no benefit in the autologous stem cell transplant arm. Means if someone is undergoing autologous transplant, either you give the platelet transfusion therapeutically or prophylactically, there is no difference. So prophylactic transfusion always doesn't help the autologous stem cell transplant recipients. Why it is important to remember? Because one may consider a practice changing by looking at this group. And this was endorsed by ASCO, saying that a therapeutic transfusion is good enough in an autologous transplant patient, so a prophylactic transfusion is not necessary. And again, this one was the randomized trial, which showed that the prophylaxis versus no prophylaxis. So the likelihood of a prophylaxis arm or a likelihood of a bleeding with a prophylaxis is less versus no prophylaxis. So we can probably conclude this part saying that 10,000 low dose of a platelets in a platelet bag and prophylactic rather than therapeutic. Then can we reduce it further? Is there anything else we can do? Can we add tranexamic acid? Can we add epsilon aminocaproic acid? There are 2 ongoing trials saying that what is called as a treat at US, B treat in Europe, where they combine the platelet transfusion along with the tranexamic acid or epsilon aminocaproic acid when the platelet threshold is low, and look at the data. They just published this one as a presentation in the last AS meeting, and this one is a plenary paper showing that when we are transfusing the patient platelet with a tranexamic acid versus those patients who are getting only platelet, there is no difference in the grade 2 bleeding. So the prophylactic tranexamic acid has no effect on the incidence of a WHO grade 2 bleeding when it is given in addition to the platelet transfusion. And even if there was no other evidence of a thrombosis, the arm which received tranexamic acid had increased likelihood of a line-related thrombosis in comparison to the arm which didn't receive. So one has to keep it in mind. The other trial that is called B-treat trial that is currently continuing in Europe. So it will be interesting to see what is their data come, but the A-treat trial shows that tranexamic acid doesn't help. And two other slides from the platelet transfusion perspective. All of us probably think that if a patient was on an antiplatelet drug and has got an IC bleed, he comes and sees us in the ER. First thing is that let us plan to transfuse the platelets. So this one was answered by a trial called as a CATCH trial. Fantastic trial, got published in Lancet a few years back. It is a randomized phase 3 trial. So which showed that platelet transfusion always doesn't help. Platelet transfusion may be helpful if you have got a really big bleed, which they have defined as a more than 30 ml hematoma volume, but that is a real huge bleed. But whenever the hematoma volume is 7 ml or 7 to 30 ml, standard care is good enough. Giving a platelet transfusion doesn't help. So this one is also another path-breaking or a thought-provoking trial trying to say that keep on giving platelet transfusion, even if someone is on either a single antiplatelet or a dual antiplatelet, it always doesn't help. And that is probably when there are no advantages, one may see that there may be other disadvantages. Is it going to increase the likelihood of a thrombosis? But at least we have the answer from a randomized trial to say that it is not helpful. And not unusual also to see the patients sometimes are on anticoagulation because of an acute symptomatic venous thromboembolism or subacute or chronic or subclinical. What is the data and how much platelet needs to be maintained? So if someone requires an active anticoagulation, like suppose someone has developed an acute thrombosis, then it is important to keep the platelet count more than 50. In a hematological malignancy or during chemotherapy, this is not unusual, trying to see. So an effort will be made to transfuse the platelet and keep the platelet count more than 50 when the anticoagulation is necessary, particularly in an acute setup. However, if the platelet count is between 25 to 50, we modify the anticoagulation dose to half. Less than 25, we hold the anticoagulation. And this comes from the data which is published both by the JTH and the Journal of Thrombosis and Thrombolysis. What should be the minimum platelet count when someone is on anticoagulation? And cause of thrombocytopenia matters. Why cause of thrombocytopenia matters? Because if you look at this upper arm is the allotransplant group. This green arm is the chemotherapy arm, and the blue one is the autologous transplant arm. The likelihood of a thrombocytopenia causing bleeding is more in patients who have undergoing allotransplant or in the chemotherapy, but not in autotransplant arm. In fact, autotransplant arm group have got less likelihood of a bleeding, so their platelet threshold can be low. They can be put into a therapeutic transfusion schedule in comparison to allo or the chemotherapy. So to conclude this part, in stable hematological oncology patients, prophylactic platelet transfusion threshold is less than 10. Higher threshold or a larger or more frequent doses always may not be necessary, excepting in the outpatient setting. Low dose is as good as high dose. And if you look at a grade 2 bleeding, that is another interesting thing to look at. It is not that the platelet count, which has got more than 50,000, will not have any bleeding. If you look at this graph, between 10,000 to 80,000, the grade 2 bleeding episodes are almost the same. So it is not that the patients, when you keep it as a more than 20,000, there is no spontaneous bleeding, but even if those spontaneous bleeding will be there, those are not significant enough to say that we have to have a change in practice, but we have to keep that one in mind. Next aspect is that, is it always necessary to give ABO identical platelet? We all know that the platelet express ABO antigen, but they are strongly expressed only in the 4 to 7% of the individual. and platelets do not express Rh antigen. Even if we say that my wish list will be to give ABO identical platelet transfusion to all, this has not been shown to have a clear benefit in terms of the clinical outcome. So ABO compatible platelet, excepting in some situation, like for example, one situation is that if someone has got really bad platelet refractoriness, it is not required that we have to always ask for ABO compatible platelet because that has not been proven that it changes the outcome. But we have to look at two aspects. When there is a major ABO incompatible platelet, the major ABO incompatible platelet is that the recipient has got antibodies against the platelet transfusion or of the donor. There is major incompatible platelet will not have any consequences. So a compatible platelet transfusion may increase the platelet count, but there is no clinical significance of the bleeding episode. But what is more important is that the minor ABO incompatible platelet. Minor ABO incompatible platelet, which tells that the donor has got the antibodies, like suppose donor is O, recipient is A, donor has got anti-A and anti-B. So if that anti-A titer is high, that is given to a recipient who has got a O, that can result in the hemolysis of the recipient RBCs. Can we say that, okay, there is clinical evidence to say that it is significant? Yes. And if you look at a FDA website, there has been 6 fatal deaths. People have died because of a transfusion of this. So this is very rare, but it is not that it is without any risk. So, and some centers usually look at antiglobulin titer, but it is not standardized. A lot of centers do not follow. So, and it is not always predictive. So even theoretical concept is there that, okay, one will try to avoid it, but it is not always practically possible. So what are the risk mitigation strategies then? So issue only ABO identical or compatible unit, provide low titer unit, or limit volume of incompatible plasma, volume reduction, washing. These are theoretical concepts, but in some situation it will be necessary, but cannot be considered as recommended in a routine standard day-to-day life. And sometimes the platelets may be added to the platelet additive solutions. So platelet additive solutions, what it does is that this replaces 65% of the donor plasma. So when it replaces 65% of the donor plasma, platelet additive solutions have been shown to reduce antibody titer by 50%. So they have been shown to reduce the allergy reaction, but their outcome in controlling the febrile reaction is a bit messy, so that clear data is not there. And it has also been shown that a TRALI or a transfusion related acute lung injury may be reduced with that. So that may be another way of reducing the antibodies when there is a clinical significance is there. What happens with the RH compatibility? So RH compatibility, we can transfuse RH in compatible platelet transfusion, excepting in one situation when we are giving the transfusion to a childbearing age lady or a female who has got RH negative, and we are planning to give the RH positive platelet. It can be given, but the recommendation is that to also to give anti-D 1 dose for the whole period of a platelet transfusion. It is not that you have to repeat the anti-D multiple times. 1 dose of a 300 microgram may be good enough. So if we try to put this one in a perspective from a ABO compatibility, be a bit cautious or at least keep a watch if there is a minor incompatibility. In a major incompatibility, it is not an issue. When looking at a RH, only look at the group or a childbearing age group for the female if there is a mismatch, because they are at risk for RHD alloimmunization. So if we want to conclude this part, so avoid minor incompatibility platelet transfusion if possible. If a center can do platelet additive solution or add that to reduce the antibody, that one will be recommended, though there is no guideline regarding that. RH incompatibility is an issue for those childbearing age patients who have RH negative blood group and who receive RH positive platelet. Consider RH immunoglobulin for those group of patients. Third part in the platelet transfusion is a platelet related adverse event, or what we call it as a TRAES or TRAES. And we all know that the patients can have a reaction to the platelet transfusion. And two types of reactions. One is a febrile non-hemolytic transfusion reaction and the allergic reactions. Uh, Febrile non-hemolytic transfusion reaction or FNHTRs are more common than allergic. FNHTR can happen in about 10 to 12% of the cases, whereas allergic reactions can occur in 1 to 2% of the cases, and it is pretty mild. And retrospective data, though there is no prospective study on that, retrospective data have shown that the children get more than the adult. Pathogenesis is different. I'm not going to spend more time on this, excepting that the FNHTR, it talks of the mainly responsible culprits here are the cytokines, both from the platelet derived and the leukocyte derived, whereas the allergic reaction here, the culprit are the donor protein and the donor derived antibodies, which stimulate the mast cell, causing different chemokines release, which causes the allergic reaction. Then, if we have this, can we use the pre-med? And the pre-med use probably will take care of the FNHTR and the allergic reaction. So Cochrane review on this had looked at this data and trying to say that there is insufficient evidence to support that the pre-medication helps in controlling both the FNHTR and the allergic reaction. Observational studies have shown that 60 to 80% of the adult patients do receive pre-medication, but it is not that it is always effective. And it is important to remember probably this data to say that 344 transfusions would require pre-medication to prevent a single febrile non-hemolytic transfusion reaction, particularly in the hematological malignancy and transplant patient in adult. So is it really worth? Do we really need to expose more than 300 patients to pre-med just to prevent one reaction? And this one was elegantly shown in this transfusion paper, which showed that the allergic or FNHTR actually doesn't get better if we give 100 milligram of acetaminophen, 25 milligram of diphenhydramine, 30 minutes prior to the transfusion. There was no difference. Other options one can plan to look at is the pre-storage leukoreduction. So pre-storage leukoreduction has been shown that it is a more than 90% reduction in the risk of TRIs because of a decrease in the cytokine level. Use of a concentrated wash product reduced transfusion plasma volume. Use of a platelet additive solution if a center can use, that will be another way of reducing TRIs. Lower two are difficult, cannot be regularly practiced, but a leukoreduction which should be at present is the standard that can reduce the TRIs to significant extent, and that should be aimed for. So if I want to conclude this part, there is insufficient evidence to support pre-medication prior to platelet transfusion. So not that all patients should as such get it as an outpatient or inpatient basis, excepting that a specific patient who has got significant reaction may be tried with a pre-med, though the evidence of that to say that, okay, it is definitely going to reduce the FNHTR, it is going to reduce the allergic reaction, at present is not that strong. And the last part of the platelet transfusion, what we need to understand is the platelet refractoriness. So always our wish list is that, okay, I'll transfuse the platelet and my intended response is 65 to 85%. So it should show that increase. Does it happen always? Unfortunately, no, because the platelet refractoriness is defined as the repeated suboptimal response to platelet transfusion with a lower than expected count increment. It may be related to immune causes, may be related to non-immune causes. So if you look at in an immune causes, the increment is the least in comparison to non-immune cases. So even if we see our intended response would be 65 to 85%, in a non-immune cases, it is 10 to 30%, and in an immune cases at 1 year, 1 hour, we see that only 3 to 5% of the patient can show a response rate. Non-immune causes are more common in comparison to the immune causes. And when you are talking of a non-immune causes, it talks of a fever, splenomegaly, drops, VH, or like accelerated platelet consumption because of DIC or hemolytic anemia, whereas immune-related causes are mainly the antibodies. Antibodies against HLA, class 1, which is more common, antibodies against HPA or human platelet antigens, or antibodies against ABO. But this one constitutes about 10 to 20%, whereas 60 to 80% is related to non-immune causes. It is important to identify this because if suppose someone has got a platelet refractoriness related to non-immune causes, no point in asking for all the anti-HPA antibodies or anti-HLA antibodies on that patient because it is pretty costly and it is pretty time consuming. And not only that, okay, I may identify that this person has got an antibodies, but if I don't have a way to give a HLA match platelet, then is it really worth going through that exercise? So when we look at an immune-based refractoriness, mainly how it is looked at is that either a CCI, what is called as a corrected count increment, or the percent platelet response. Both CCI and the PPR, they look at a platelet increment, excepting that the CCI uses the body surface area, whereas PPR uses the blood volume. So overall, if you look at most studies will define refractoriness at less than 5,000 after 2 subsequent transfusion. Overall recommendation is one has to do up a 1 hour post platelet count, but in a practical scenario, it is not always done at 1 hour. Mostly people will do it at 10 or 15 minutes, trying to see that whether there is any increment or not. A CCI of 7,500 less than that, or a PPR of a less than 30% are also acceptable. And this is the way how it is calculated, like a post-transfusion platelet count, pre-transfusion platelet count divided by how much platelet we have transfused. And identifying the antibodies are almost similar to how do we identify in a transplant, like a donor-specific antibodies or panel reacting antibodies. So platelets, as you all know, they express the class 1 HLA. So the class 1 HLA can be antibodies against HLA A, B, or C. Most platelets predominantly show that HLA A and B alleles. The antibodies of HLA C are not significant. It is not about a class 1 HLA. The platelets also have got platelet-specific antigens. And there are about 35 known human platelet antigens. Sometimes antibodies may be related to that, but this is much less common in comparison to the class 1 HLA antibodies, because this is only implicated in less than 10% cases, platelet-specific antigens. Rarely, it can be also related to ABO incompatibility. So if there is a refractoriness related to this, one may consider giving them the ABO compatible blood or ABO compatible platelets. So if we look at from the percentage wise, the most will be against the class 1 HLA, few will be platelet specific antigens, and again, few of that will be the ABO incompatibility, which can cause the antibodies in the platelet, which are not allowing appropriate or adequate improvement in the platelet count. And one should not forget about the drugs. Quite common drugs like the antibiotics, what we use, like piperacillin, tazobactam, like the other drugs, if someone is using a ceftriaxone, someone is using a vancomycin, or the other drugs, there is a drug-dependent platelet antibodies. So if someone is not that septic, someone doesn't show any HLA antibodies against the platelet, but the platelet count increment is not happening, always open your mind and always think about that can it be related to the drugs or some drugs which are responsible in causing the platelet antibodies, are they responsible for those? Universal pre-storage leukoreduction that does the alloimmunization. This is a fantastic paper which got published from the Canadian Blood Services. And once it got published in 2004, subsequently, that has been a game changing. Now the recommendation is that it is always important to you to do a pre-storage leukoreduction. And the Canadian Blood Services in this paper showed that how the refractoriness can significantly improve by doing a pre-storage leukoreduction. Overall, when we look at the overall refractoriness, or you look at in a chemotherapy group, you look at in a transplant group, or whatever the group you look at, the pre-storage leukoreduction helps in reducing the alloimmunization and subsequently the refractoriness. So when you think about a refractoriness, first suspect, because you have given an adequate dose of a platelet, but patient is not showing a platelet increment. So first is the suspicion. Before you suspect, do consider that an adequate platelet transfusion has been given or not. Because if you have given a very low dose of a platelet transfusion, and then if the platelet count is not improving, then you know that, okay, this may not be increasing because I have given such a low dose that it is not expected to increase. And then next thing comes, so answer two questions. Is the patient truly refractory, or this is your assumption that the patient is not increasing? So do a pre-transfusion platelet count, look at a post-transfusion platelet count, look at a CCI, and then identify that whether it is a true or false. And if it is a true, next question comes as immune versus non-immune. Because non-immune causes, as I mentioned, it can be up to 70 to 80%. So do not immediately ask for a platelet HLA antibody test, because as I mentioned, it is time consuming, it is costly, and you can only intervene if you subsequently are able to get a platelet the match platelets. If you are not, then going through that exercise may not always be useful. That may be only academic. So first look at a non-immune factors to remove it. But if it is not, or there are no non-immune factors, then do put an effort in identifying if there is an HLA antibodies. If you are looking at a HLA antibodies, what policy we follow here? We transfuse the patients. Our threshold, as I mentioned, is 10,000. We transfused here the buffy coat platelet. So we give one bag of a platelet, which has got pulled 4 bags of a buffy coat. We do the platelet count every day for 3 consecutive days. If we see the platelet increment is not more than 10, we, after ruling out some non-immune causes, we ask for the HLA antibody test for those patients to identify if there is a possibility of presence of any HLA antibodies which is causing this refractoriness. And if we get HLA antibodies positive, we ask for the HLA match platelet. So I think there has to be a thought process, there has to be an algorithm trying to follow how it is, rather than asking for the HLA platelet antibodies for all patients, because sometimes it may not be always beneficial. And in some situations, there may be combined immune and non-immune factors, and that has to be kept in mind too. There are different ways of looking at it. I'm not going to go through this one in detail, and how the genotype analysis will be done and how the HLA platelet antibody testing will be done because of a lack of time. But there have been multiple good reviews and the protocol guideline how it can be done. People have used sometimes the in vivo adsorption strategy to remove the platelet antibodies. People have used the eculizumab, but first is the suspect, confirm, rule out non-immune causes before you go in this direction. So then I will probably touch upon few of the guidelines. I know that I'll probably try to finish in next 7 to 8 minutes, so that we can have some discussion. So when we look at a platelet transfusion in critical ill patient with the thrombocytopenia, there is insufficient evidence, because this question always comes that what should be the cutoff in ICU? Patient is not bleeding, but patient is pretty sick. What should be the cutoff? So people have looked at, or experts have looked at in a different clinical scenario, and they have looked at in the critically ill adult patient, there is insufficient evidence to say that a platelet transfusion helps. For critically ill preterm units, severe thrombocytopenia, there is insufficient evidence to make a recommendation for or against. Same thing with the children with a severe thrombocytopenia. So in a current recommendation for a non-bleeding critically ill patient, platelet count around 20,000 is good enough. You can only transfuse the platelet if it is if someone is bleeding. And this one is from the JPAC and the joint UK recommendation only for adult critical care. Non-bleeding patient with a severe sepsis, hemostatic abnormality not indicated. In a non-bleeding with a severe sepsis and hemostatic abnormality, try to keep it at 20, not more than 20. But if someone is bleeding, then the threshold can get changed. There are 4 guidelines in a platelet transfusion. Very nice guidelines. A lot of effort has been put in preparing these guidelines, or there is a appropriate methodology has been followed, and people have even looked at compared all the guidelines, trying to look at a methodology and how strong those are. So there are 4 guidelines. One is the BCSH guideline, got published in 2017. This is an important guideline from the International Collaboration for Transfusion Medicine guideline called ICTMG. ASCO guideline specifically for the oncology patients and transplant, and ABB published guideline few years before, looking at what are the clinical practice guideline. So I'll mainly probably touch upon the BCSH and the ICTMG with a little bit of a focus from the ASCO, because all these things are, as I mentioned, they're quite collaborative or trying to say the same things much more commonly. As I mentioned, I'll go a little bit faster in this guideline. I'm not going to go into very detail. What ICTMG did is that they asked few questions and they tried answering those questions. What should be the threshold, and should patient with a hypoproliferative thrombocytopenia receive prophylactic transfusion? The recommendation was that yes, if there was any bleeding. What platelet threshold? Platelet threshold of a 10,000 is good enough. One should not go for a higher dose. And patients who are having clinical significant bleeding, try to keep the platelet transfusion more than 10,000, but there is very weak level of evidence here. Why very weak level of evidence? Because if you remember the graph what I showed you from the Plado trial, the bleeding episode doesn't change between 10,000 and 80,000. So keeping a platelet count at 20,000 versus keeping a platelet count at 50,000, there is no difference in the number of bleeding. So that is the reason they say that even if the wish list is higher, there is no strong evidence, or there is a very weak level of evidence. Low dose of a standard platelet transfusion is good enough, means 1.1 into 10 to the power 11 per meter square is good enough, or is as good as 2.2 versus 4.4. If we give a low dose, then probably frequent transfusion can be less, but in an outpatient setting, depending on the clinical situation, one may change. Should patient receive ABO match platelet? No, it is not always required. Only if it is required if somebody is showing any refractoriness. Again, weak level of evidence. Patients who have got a RH antigen negative, is that required that everyone will require RH negative platelet transfusion? No. Again, it is only for those patients or female who are childbearing age, where if somebody is RH negative, those group of patients may require RH negative. If not practically possible, they should get an anti-D. Should patient receive HPA selected or HLA selected platelet count? No, depends on the refractoriness and depends on how extensive the investigation has been. Always keep in mind that non-immune is more than immune. Looking at the other questions, like a patients who have got a refractory transfusion, will they receive a prophylactic, or should they always receive a HLA match, HPS selected, or a cross match? There is a weak level of evidence from that perspective. This is important. Should patient receive apheresis-derived platelet instead of a whole blood-derived platelet? No strong evidence to say. It is a moderate level of evidence to say that when a leukoreduced platelet products is available, then one can use the whole blood platelet as a or a therapy method, because that is as equivalent as like apheresis platelet. But suppose you do not have a leukoreduced platelet count, which is from a Buffy goat preparation, then try to use the apheresis platelet if possible. But if your blood bank is producing a good leukoreduced platelet, that is as good as like apheresis platelet. So they put their guideline into a cartoon. So look at what is the indication of platelet transfusion. Platelet count less than 10,000 or more than 10,000. Is the patient having antibodies or the refractoriness? And if there is no refractoriness, then apheresis over a whole blood platelet count is good enough. Always follow a low dose platelet transfusion. Unless it is an outpatient recommendation or patient cannot come frequently, then go for a standard dose platelet transfusion. RH negative versus RH positive, only give the RH negative blood to those female bearing or a child bearing age, female with a child bearing age, where it is really necessary, and then give the anti-D at the end of that. And most of these things have been proven by the BGH or was recommended by the BGH. And they did talk of a number, they did talk of a threshold. So I'm not going to go through this one in detail again, because we can have some time for a discussion. The only point what I would probably say, or what is more important, is that two things. We all know that in a ITP or a TTP or an HIT, platelet transfusion are not recommended, but it is not that it is absolute. If a patient has got bleed, one needs to make a decision in giving platelet transfusion. If someone is planning to go for any invasive procedure, platelet transfusion can be given, but along with IVIG, and then one can add tranexamic acid or the other medication to reduce the bleeding. In a post-transfusion purpura, intravenous immunoglobulin is the treatment of choice. Actually, there is a publication which talks of the myths about platelet transfusion in immune-mediated thrombocytopenia. And the authors say here that probably it is only in our mind rather than a very strong evidence for that. So if someone has got active bleeding, rather than saying that, okay, it is immune related, I'm not going to give platelet, sometimes platelet transfusion can be given, but along with the other measures which can control the bleeding. In comparison to the other guideline, what BCHS did is that they also put one more or a group of recommendation trying to say that what should be the minimum platelet count. It is important mainly for the residents and the fellows. So do not give platelet transfusion routinely to the bone marrow aspirate, or if you are inserting a PEEK or you are removing a line or in cataract surgery. So these are the indications irrespective of platelet count you can do. But the platelet threshold with the time passing by is gradually changing. Why I'm saying that? Because if you're putting a central venous catheter, 20,000 is good enough. But look at what is the recommendation with a lumbar puncture. Lumbar puncture platelet count recommendation is 40,000. You do not need to have a 80 or 100,000 when you're doing a LP. In a major surgery, it is 50,000. But if you're putting an epidural catheter, it is 80,000. And in neurosurgery, try to keep it as 100,000. Liver biopsy for a transjugular, anything is good enough. Percutaneous liver biopsy is 50,000. But what is more important is that if you are planning to get a renal biopsy, you plan to keep the platelet count more than 50,000, but it is important to look at why the patient has got a platelet count low. Is there any platelet dysfunction? And they actually recommend platelet transfusion should be avoided in renal failure. And that is almost a recommendation grade 1B, because the platelets what we are transfusing may develop the same dysfunction unless the creatinine is getting improved. So it is not a go to say that, okay, all patients with a renal failure going for any procedure will require a platelet transfusion. And if a renal biopsy is urgent, do consider DDAVP if possible. So in a bleeding, detail, but just say the platelet count is 50,000, platelet transfusion in a non-severe bleeding, 30,000 is good enough. But in intracranial bleed, try to go keep it at 100,000. There is a congenital or acquired difference or a platelet dysfunction where they differ in the different threshold I put, but which is also important to see that probably this one in a clinical practice is not seen that unusually. And their recommendation is that do not use platelet transfusion pre-procedure when the antiplatelet agent have not been discontinued. And a randomized trial has shown that it always is not helpful. Patients who are on aspirin or other GP2B3 antagonist, then use the general hemostatic measures rather than the platelet transfusion. Try to use tranexamic acid. And if someone is having a critical bleed, then only plan to use the platelet transfusion. Tranexamic acid or the other fibrinogen product, if someone is bleeding, like a cryoprecipitate or a thrombopoietin receptor antagonist, and or the agonist are the other drugs which can be used or which can be considered in a bleeding rather than inadvertently giving a platelet transfusion. But the recommendation for the platelet refractoriness is almost the same. First, identify the cause, immune or non-immune, and then see what type of platelet transfusion one may plan to give. But what is more important also to say, and this paper looked at all the quality of evidence guidelines, that the guidelines are published, different experts have looked at it, but what are the quality of evidence? So this paper looked at all the guidelines and tried to say that, okay, the quality of evidence is very strong, but there is presence inconsistency. So depending on which guideline you are following, there may be a variation between the clinician. There may be variation between different people who are recommending what should be the threshold. So there is nothing right or wrong. So there have been, even if the experts have written the guideline, it is always important to remember that it is not that everything is evidence-based. Everything is based on the phase 3 randomized trial, because a lot of trials are not existent. So there are inconsistency even among guidelines. So that one may need to remember. So to conclude, platelet threshold in most clinical situation is 10,000. Low dose platelet transfusion in a platelet bag is sufficient in most clinical situations. We don't need to give a higher dose. Pre-medication should not be the standard practice to all or prior to all platelet transfusion. Platelet refractoriness may need to be addressed in a specific clinical scenario, not in all cases. It is important to follow the evidence-based clinical guideline while considering transfusion, but do remember there is presence of inconsistency, and try to keep that one in your mind whenever you are recommending how the platelet transfusion will be required. Always do remember that no blood product is 100% safe. So unless there is an absolute indication, do not just recommend that, okay, this person's platelet count seems to be low, or number wise it is low, patient is not bleeding, but I'll go ahead and give transfusion if it is not indicated. Because none of the blood product in the best of the blood bank in the world, one can say that this is my product is 100% safe. Thank you, and we'll be happy to see any questions, or I know that the panel discussion most likely will be after this. Thank you very much.
Thank you so much, Dr. Oro, for that great lecture. A lot of doubts have been clarified, and I think it will improve the quality of practice in this country remarkably. Thank you so much for doing that job. So we're going to take questions from the faculty here, one by one, based on the raise hand sign. I request the faculty to ask one question. Let others also ask their question. We'll come back for the second round and the third round. So let's begin with Dr. Dipankar.
Thank you, sir, for this excellent talk. Sir, I have a case. There's a 45-year-old Navy officer. So in 2008, he presented with a fracture of the acetabulum, and the routine investigation, he showed cytopenia, pancytopenia. So doing the X-ray, the orthopedic surgeon diagnosed him as osteopetrosis. And at that time, a bone marrow was also done for the cytopenias, which was suggestive of myelofibrosis. He also had the constitutional symptoms at that time. So he also had splenomegaly. So he was counseled about transplant, but he did not have a HLA match. So he was started on ruxolitinib. So he was maintained like 5 to 10 mg BD, and cytopenia still persisted. The issue was he was having a low hemoglobin and a low platelet count. So he was transfused 2 unit PRBC and platelets, but on the third occasion of platelet transfusion, he had a hemolytic transfusion reaction. So a phenotyping was done, and a RBC phenotyping was done. So it was showing that anti-U antibodies were there. So that was a very rare thing. And he could not find a compatible match blood and a platelet. So now the issue is he is having a low hemoglobin, a low platelet like 10,000. So what should be done in such a case?
Difficult case indeed. But I would probably, what I would have done, I would have taken this person for an unrelated transplant or a haploidentical transplant. Because this patient is young, and I presume he is in a good performance status. He already has got an antibody against a rare antigen, and for which, for you to find an appropriate match blood transfusion or a blood product will be extremely challenging. He already has got an advanced stage of myelofibrosis. Even if there is no HLA match donor, the only way here, how we can say that his own hematopoiesis needs to be changed, and he has got a grade 3 fibrosis, the myelofibrosis, this will be an absolute indication for an alternate donor transplant. So, and that may be in the long run from a transfusion perspective, from his overall disease perspective, that may probably will be better.
So any role of plasma pheresis or immunoglobulins which can be done, because in a transplant also setting, he'll need platelet transfusion and blood transfusion. So how to mitigate that thing?
I think all those things will be for transient, because you have asked what is the goal of care. If someone is a goal of care is that is going in a palliative direction, that is different. But if we are to look at a curative intent, Either you do a plasmapheresis, or if you give a IVIG, those will be only for a transient process, maybe for about 21 days. Then you have to repeat those, and those cannot be continued lifelong. There are definitely the way how you can bypass this during the transplant process. Body. Transplant is not contraindicated, but there are ways to bypass this by giving IVIG, by doing plasmapheresis, by giving rituximab, and then one can bypass during the transplant process. The care will be important there, either it is a definitive or a curative intent or a non-curative.
Yes, sir.
Thank you. Dr. Tushar?
Yes, sir. Thank you, sir. So, Dr. Oro, my question was regarding platelet transfusion in HIT patients, ITP and TTP patients. So, I think you have talked about both of them, both of these patients. So, I would like to ask whether platelet transfusions are best avoided in these situations. Is there a substantial evidence of it? And if they are, they can be transfused when a patient is requiring an interventional procedure, which is urgent basis, can they be still given in these patients?
Thank you. I think that is a very important question. There is no evidence-based guideline. First, to start with that. But there is no evidence-based guideline either to say that a transfusion cannot be given, excepting probably if you divide the groups into ITP, TTP versus HIT, it is more stronger in a heparin-induced thrombocytopenia, then TTP, then ITP. So the recommendation overall is that patients can be transfused if there is either an invasive procedure is planned, but you have to give in more number of platelet transfusion. Their routine standard platelets will not work. And before that, you also need to put an effort in saying what other drugs can be added, what other intervention can be added to see that if a platelet transfusion, if not absolutely indicated, can it be avoided. But if suppose someone has got, think about a situation, a ITP patient has developed a big long mass. You need to know that whether it is a lymphoma or a long malignancy. Saying that okay, if IVIG is not increasing his platelet count, and then trying to not transfuse the platelet for some reason, if the patient cannot go for a splenectomy or cannot receive the other thrombopoietin analog, but you need to get diagnosis at the earliest within 24 to 48 hours. So in those type of situation, transfusing with another or the additional medication is not a wrong thing. That is the reason why I showed you that paper. People have put it as the why people consider it as a myth. There is no strong data about that.
Thank you.
Thank you.
Dr. Rajat Jain. Dr. Rajat, unmute yourself. Unmute.
Hello, sir. Good evening, everybody, sir. Sir, I just I was seeing a lecture. You have mentioned in aspirin when the patient is taking a aspirin pre-op.
I'm sorry. I'm sorry. I'm not able to hear your voice.
Hello.
Okay.
Am I audible, sir? Am I audible?
Yeah. It is clear now.
Yeah, sir. Sir, you just told that if the patient is on aspirin and he is pre-op, like he needs to be operated for a tumor, do not need to give him platelet transfusion, sir. But this is what we have read in the books, that like if patient is pre-op and he has taken aspirin 1 or 2 days before, we should transfuse him the platelets. Secondly, if such a patient develops a bleeding, like how frequently would you transfuse him the platelets? Like every once a day or twice a day? How would you manage such a patient if he develops a intracranial bleed and he was on the aspirin 1 day before the bleed?
Sure. Thank you. So there are two aspects here. What I told is that a patient who is on an antiplatelet drug, either single or a dual antiplatelet drug, he comes with the bleed, including IC bleed. There is no strong recommendation from a randomized trial to say that platelet transfusion is going to be helpful in that situation after someone has developed a bleed. And that one is the patch trial, which is published in Lancet, and it was a randomized trial. Because people have looked at, if you give a platelet transfusion plus tranexamic acid plus taking that person for a surgery versus tranexamic acid, surgery, or other intervention, there is no difference in the outcome. But that's one question. To say that a platelet transfusion after developing a bleed alone is not good enough. Second thing is about a pre-op. If suppose it is there are two ways of looking at it. If patient has taken aspirin, is it possible to hold it, and is it possible that the elective surgery can be delayed or not? It may not be possible in all practical situations. Someone may need to continue that, when the surgery has to be done. In that case, one may need to look at what is the half-life of that drug and when the platelet transfusion can be given. But not only that, also combine the other non-hemostatic or other ways to take care of the hemostatic way. Like a high dose of tranexamic acid may be helpful over there. One may stop the drug. What the guidelines say, do not just transfuse the platelets without stopping the drug, because a lot of time people continue the drug and give platelets. The function has been taken care of. That is not the case. So first hold the drug, give from the tranexamic acid, wait for the half-life to go down before, if it is an elective surgery. If it is not, then one may have to give a platelet transfusion and go for that. But that is, if you'll ask me, is there strong evidence for that? No, there is no strong evidence to say that. Almost about 10 years back, I will tell you the name of that person. You can probably see from a Mass General. He published a fantastic review. His last name is DZWIK, that how people have used the platelet transfusion in this different operative setting without a strong evidence, without a strong data. And this is almost a 30 or 40 pages article comparing those. To say that, okay, we may see or we may say something that is necessary, but there is no strong guidelines to recommend those.
Thank you. Dr. Asif?
Yes, sir. Sir, you probably will know, sir, we have a pioneer researcher in coagulation in India, Professor Kanzaksha Ghosh. In one of our meeting, he explained that when we do not have activated factor 7, we can use recently expired platelets, day plus 6 platelets. They are more prothrombotic. After that, I have tried convincing my transfusion medicine colleagues, but I could not find any evidence also in books, and also like my transfusion medicine colleagues also do not agree. Sir, do you think we can use recently expired platelets in lieu of activated factor 7 in possibly in those situations where there is life-threatening bleed and possibly activated factor 7 is not available or cannot be used?
I personally will not. I do not think there is very strong data to say that it is effective. It is not about if a strong data is not existing, and we know how the blood product can be so unsafe sometimes. And to remember, if you look at a blood, if you look at platelet, if you look at FFP, if you look at cryoprecipitate, the drug which causes maximum, or the blood product which causes maximum infection, including life-threatening infection, is platelets, because that is stored at room temperature. So then in the absence of a strong data, knowing that a product is going to cause more side effects than doing any good, am I going to recommend or am I going to use the expired product? No.
Thank you, sir.
Thank you.
No problem.
Just a word of caution to everybody. Trying to do anything that is not existing in the literature, in the guidelines, these are the days where you can get into serious trouble and nobody can save you. So be very careful. Okay, Dr. Pankaj and Tandia.
Thank you, sir. Dr. Oro, thank you for such a great lecture. I'm sure from tomorrow morning, we will avoid giving unnecessary transfusions, which we are usually giving nowadays. So I have a very simple and straightforward question. We are giving daily induction therapies and transplants. So we have a basic mentality that if a platelet count is less than 25,000, then we usually infuse, we go for RDP or SDP transfusion. So what will you suggest? Whether it should be on account of bleeding, or the limit of platelet count should be less than 10,000 or less than 20,000 for transfusion? Please specify.
Thank you, Dr. Pankaj. So two things I want to probably comment. So first thing is that with a platelet transfusion, our transfusion medicine colleagues here are very strong. Even if I say that, okay, I need to transfuse, they will say, so they will not even release the product from the blood bank. So that is to some extent is good, because there has to be someone who is controlling, rather than whatever I say, they will consider that that is the best guideline. No, it is not. Second thing, for all our patients who is either a leukemia or an auto transplant or a allo transplant, we put a threshold as 10,000. We never transfuse anyone who is having a platelet count more than 10,000. Excepting in separate situations, like if someone is having active bleeding, or someone in the past is known to have bleeding if a platelet count goes down to less than 10,000. Excepting this group, either it is an inpatient setting or an outpatient setting, it is always a 10,000. In fact, we all have to fill up a form, and that will go to the blood bank, where for the RBC, platelet, or the plasma, there is I have to put as a clinician, why do I think that more than 10,000 is necessary? So there is a column. Unless I fill up that, they will not give release. But our overall cutoff, and we have not seen any increase in the bleeding, even in our allotransplant settings, we put a cutoff as 10,000.
Thank you, Pankaj. Dr. Rajesh Sawant.
Well, thank you, Dr. Oro, for that very nice coverage of all aspects. So my question, Dr. Oro, is about the use of platelets in additive solution. When we use platelets in additive solution, how important it would still be to give due consideration to the blood group specificity of the platelets in the bone marrow transplant setting and in the non-transplant setting. What is your experience about the use of these platelets in additive solution?
Thank you, Dr. Rajesh. I'm not an expert, as I mentioned in the beginning, that about platelet additive solutions, but I can only tell about our comment about the blood grouping. We do not use a blood group specific platelets unless it is really necessary, because it is not evidence-based. And if you have got a blood bank which is not catering to multiple hospitals, and if the blood bank will start using only the specific blood group platelet, there may be a lot of platelets which will get wasted. Even if our blood bank is a huge blood bank here, takes care of about more than 3 to 4 hospitals, and this is the central blood bank here. So inventory is never an issue, but still they will not recommend, or they will not issue us always a blood group match platelet. They have got plenty. And if we look at evidence-based guideline, it is not necessary.
Okay, that's great. Thank you.
If you can do, that is better. If you are not able to do, there is no harm.
Absolutely no harm. Correct. Thank you.
Yeah. Thanks.
Thank you. Dr. Tufan, your question is still there, or it's sorted?
Yes, sir. Yes, sir. I have a question. Dr. Oro, thank you very much for a wonderful lecture. So my simple question is that, because in the platelet refractoriness is very common in the plastic anemia setting, so we are facing a lot of problem in the platelet refractoriness in the plastic anemia. So after the diagnosis of this, the platelet refractoriness with the CCI, so how practically we approach to transfuse the platelet and to salvage the patient?
Sure.
We already discussed it.
That is a question which is probably throughout the world is challenging, particularly if a patient who has got a chronic thrombocytopenia, not actively bleeding, but requires intermittent platelet transfusion, how one will approach that. So the first thing is that in an aplastic anemia, it is, even if the threshold is less than 10 for most of the patient, but if you look at a trial, in trials, they have excluded the aplastic anemia and myelodysplastic syndrome because they will have chronic thrombocytopenia. So if a platelet count of 10,000 is recommended for those patients, that is an open question. So overall, in those patients where we know that if we are not giving any definitive therapy, their platelet count is going to be low persistently. If in the clinical situation is good enough, one may consider keeping the platelet count around 5,000. We do transfuse at 10,000, but there have been some situations where we are not able to transfuse. We can keep the threshold a bit low. At least doing an HLA match platelet, we first look at the HLA antibody HPA titer. So we don't ask for a genotype always. but at least we look at if there is any immune related factors which is causing the platelet count to be low. It is not that we always get a HLA match platelet. If a HLA match platelet is not there, we do transfuse them non-HLA match platelet, but with a higher dose, trying to see that whether the higher dose is able to bypass them. That will be one situation also where we will plan to use a ABO match platelet, because it is not that always the immune related is only one specific cause. There may be multiple causes for it. So we'll plan to use a ABO match and then try to use HLA match platelet is not available, but we will always try asking the Canadian Blood Services for a HLA match platelet, and most of the time they are able to give. So I know it is not always practically possible in all places to get it, but in those situations, my practical advice will be trying to use a ABO match, not to transfuse unless it is absolutely indicated. And then if a test can be done, trying to say that, okay, the HLA matching can be done, at least you can document that. And those patients, you can use tranexamic acid so that at least the patient is not having actively bleeding. We usually send even some of our leukemia patients with a tranexamic acid.
Thank you.
Thank you. Thank you very much.
Thank you. Dr. Akanksha.
Yeah, hello, sir. Thank you so much for that wonderful talk. So I'd like to ask you, how do you manage SDP refractoriness in patients who are undergoing allogenic transplant? And especially like in our setting where we don't have always the availability of HLA matched platelets. And many a times, most of the patients do become refractory even to group match platelets. So how should we approach such patients? And what cutoff of the platelet count do you recommend should be kept for patients undergoing allogenic transplant?
Sure. Thank you, Dr. Akanksha. So first thing is that our cutoff doesn't change. Cutoff is still 10,000 in all patients with an allogenic transplant, even if they have got a HLA refractoriness. So it is not impractical for us to say that we are transfusing them every day and their platelet count is 5,000 or 6,000 comes back. We still do not transfuse them if their platelet count is 5,000 post transfusion or by next day morning. Our cutoff number wise it is 10 unless someone is bleeding. We do ask, as I mentioned, we do ask for that test for HLA refractoriness. It gives us whether it is a HLA antibodies or antibodies against HPA. They do ask the blood services to find out the HLA match and platelet and to provide us during the allo transplant. But I would probably say there are significant incidences where it is not possible. Either you are not getting a HLA match platelet or blood bank is not able to produce this. We do at that time the random donor platelets. Well, we don't use this apheresis single donor. We use the buffy code, and that buffy code remains a constant for all patients. We don't go for apheresis platelets. But we don't react to a number. If I have transfused and the platelet count comes back, suppose by evening, 5,000, the patient is not bleeding, will he require a transfusion? No, we don't transfuse. Even that person is having fever, as I mentioned, fever is not an indication for us to increase the platelet count. So it is always important to see that we can get a HLA match platelet if it is available or it is accessible, that is good, but practically it is not always. We follow the routine process as it is. In a transplant, it is a little bit different. I'm not talking of a platelet. If it is a stem cell donor who is developing an antibodies, we do different maneuver to that, like a IVIG or a plasmapheresis, but not for a platelet transfusion.
And have you ever used the donor itself for apheresis platelets for the recipient?
Never.
Like suppose if you don't have any.
Never.
Okay.
No. We will not use, and in fact, the why will not use is that is no strong recommendation about that. The only recommendation has been if you're taking someone for a transplant, that person has got a donor specific antibodies. Then when you are collecting a stem cell, you can take the buffy coat and infuse it one day prior to the transplant. But that is also in some space center recommendation rather than it is a widely accepted guideline. So we'd never put the donor on the machine to collect platelets.
Thank you.
Thank you. Dr. Gopinathan.
Good evening, sir. Thank you very much for the lucid talk. So quite often we do see a difference in clinical phenotypes of bleeding. Say, for example, in a case of severe aplastic anemia, at 15,000 platelet count, one child tends to bleed, whereas the other child comes stable walking to OPD when other causes like fever and all are ruled out. So how to account for this heterogeneity in presentation, bleeding phenotype? Is there any mechanisms at the cellular level which can, which can be translated clinically for this type of bleeding manifestations?
Thank you, Dr. Gopinath. That is probably the question where I have to go to the genetic level, but probably may not be required. But what is necessary to understand is that even both twins are not the same. So there are always variation. It almost depends that a lot of a phenotypic and the lesson trying to even with the same phenotype, why the phenotypic difference will be there. So that would patient. If you think that you are following up a patient who is overall stable for a pretty long out versus other child or other patient count below a threshold, then probably for that patient, addition of any other hemostatic agent or keeping a threshold a little bit higher will be necessary. But which is more important is to identify why that person is behaving like this. But finally, it will boil down to the genotyping and phenotyping correlation. There is no single answer to that. One may need to look at it in a much more detail, trying to see that why this person is behaving different.
Thank you, sir.
Thank you, Dr. Gopinath. We'll take a few questions from the audience. There are a couple of questions related to, in various settings, if patient is not bleeding and there is a stable platelet count of 5,000, will you infuse?
Depends on the type of disease. If it is aplastic anemia, I will not transfuse. If a patient with a leukemia, then I will transfuse, or a transplant, I will transfuse. I may not transfuse to an auto-transplant patient, I will transfuse to the allotransplant patient, looking at the likelihood of a bleeding is more in there.
So you covered many of them. One of them also is viral infections like dengue.
That is always a challenge. How much should be the platelet count? I will not transfuse unless someone is having bleeding. How low you can wait? I will still probably say less than 10,000. Can I? Am I becoming much more confident? Yes. When I was in India, I had dengue. I had a platelet count of 17,000, and I didn't get a transfusion. I developed petechiae. I thought, okay, fine. Petechiae and ecchymosis is fine, but I will not transfuse even myself if a platelet count is not less than 10,000.
Thank you. Another question is, how do you establish true platelet refractoriness?
So group platelet refractoriness, sorry, I couldn't understand that question. Is it like
true platelet
refractoriness? I think you have to do up an HLA genotyping study, because if you really want to look at that the true platelet refractoriness after ruling out all non-immune causes, most likely it will be immune related, but to confirm that, you have to do a platelet genotyping study, which is very extensive, and a lot of blood banks, even in the best countries in the world, they will not be able to, because specific lab will be able to do that. But to confirm that, one has to do a genotyping study. But as I mentioned, a lot of times the refractoriness is a combination of immune and non-immune. So one thing doesn't exclude the other.
Thank you. Another question is, what do you exactly mean by hypoproliferative thrombocytopenia?
Yeah, so I don't like that term, but I cannot bypass it because most of the guidelines, they talk of that. I cannot bypass a guideline. But when they're talking of a hypoproliferative, they generally talk of your megakaryocytes are less. So I'll have to differentiate it from immune.
Production versus destruction.
Yeah.
All right. If a patient has AML and induction therapy is on and patient is febrile, are you still comfortable with the platelet threshold of 10,000?
Yes, we do. We do not transfuse even if I am treating a patient with the AML. If I know that in the morning I have given him platelet transfusion, in the afternoon he gets fever, I do not transfuse platelet if his platelet count is 10,000, but he doesn't have any bleed. So there is strong evidence, and there is a good article in the Blood as a commentary which has got published, saying that we are probably following a practice which is more than 40 years old, when the only drug which is available is acetylsalicylic acid.
Another question is, a patient who requires platelet support before undergoing major surgery, you give it before the surgery, and do you also continue during and after the surgery?
We do not, except if it is a critical procedure. If it is a critical procedure and the patient has got a past history of not increasing the platelet count after transfusion, then only we will repeat. But otherwise, we do not always document a normal platelet count prior to surgery, because within that period of 10 or 15 minutes, you may not always be able to document that.
Thank you. There's another question. In aplastic anemia who requires both Paxil and platelet on a particular day, is it recommended to give platelet before giving red cells, or there is nothing like that?
There is no strong evidence like that. That is always in our thought process. If I want to extend it from a physiological perspective, to some extent, that will be probably better. The only reason is that when you are giving a platelet transfusion, you are trying to maintain the vascular integrity before giving a blood. But there is no strong basis for that. Like, it is not that you are trying to push your hematocrit in aplastic anemia to really high 11 or 12, where you can think that the chance of bleeding will be higher. You are probably transfusing the platelet, giving a blood if the hemoglobin is less than 70. So one transfusion is not going to push that hematocrit high, but the likelihood of a bleeding will be there.
Another question is, during ATG therapy, what is your platelet threshold?
It is always 10,000. Because I think the likelihood of a bleeding, as I mentioned, among all disease perspective or with all risk, will be the maximum in an allotransplant setting. Still there, it will be 10,000, excepting the patient, if the patient has got a veno-occlusive disease, patient has got a bad graft versus host disease with other reason for a bleeding, there we'll keep it as 20, but always it is 10, irrespective of the drugs what we are using or procedure.
Thank you. Is there a platelet threshold for taking COVID vaccine?
Not really. I do not think so that there will be any platelet threshold for a COVID vaccine. I can probably extrapolate that. If a patient with a hemophilia requires a vaccination, are we keeping up any threshold for factor level? No. So it is just like extrapolation of that. No platelet number is good enough to say that, okay, that one is necessary.
Is there a particular platelet level for doing bone marrow trophine biopsy?
And no, even it can be done at platelet count of 0.
How many times can a person undergo platelet donation by pheresis? At what intervals?
I think that depends on each of the blood bank recommendation, and it is a country specific recommendation. Mostly the people will probably plan to go ahead within 3 months, unless there is any absolute indication for that. But I think that one will be depends on the each country's guideline and their blood bank guideline.
Thank you. Dr. Pankaj, you have a question? Unmute yourself.
Sorry, sir. My another question is again regarding patients with induction therapies and transplants. Generally, we give RDP and SDP infusions. It goes very smoothly, but sometimes it happens that all patients given RDP in the same day got severe hemolytic reactions from that product, and few of them even lost their lives. So, is there anything what we can be get alarm previously that yes, this is going to get react, or anything else what we can check with that product?
My only suggestion will be that if that has happened and if you see somebody is really developing a bad hemolytic reaction, then look at if there is any minor incompatibility between both. Because sometimes a O group platelet, if that person has got a very high anti-A titer and it is given to a group blood, that is the group of patient who develop really severe reaction, and it has been documented that can cause fatality. So if that can be avoided, and you can see if there is a way of not giving him a minor incompatible platelet, or find out a way how your lab can do an anti-A titer of the patient and the donor, trying to see that what is happening from there.
But how can it happen? I mean, there must be some problem with the product, because every patient on the same day get the same reactions like this. So is there anything regarding to the product or the process of that?
That will be that will probably another discussion which is very close to my heart, to look at a quality assurance and the quality control of the lab, of the blood bank, of the how it was produced, how long it was kept outside. But that will probably is a total different discussion.
Thank you, sir.
Thank you. Dr. Dharma?
So, I have one question. Many times it's a rare, but when the healthy donor get GCSF, and on day 5 or sometime day 6, when you're doing harvest second time, the platelet count goes down to 40,000, 50,000. So do you recommend platelet transfusion before second harvest? Because the many times the blood bank insists that there will be consumption, the lot of ACD. So from the donor's perspective.
Yeah, no, I think Dharma, that is a good question. Only thing is that first thing, don't transfuse, even if it is because our cutoff will be 50,000. And that is not a common occurrence. This will be extremely rare after 4 days of a GCSF if someone has taken, and the second day, our cutoff of putting on a machine is between 20 to 30,000, even if they are using ACD. So if a patient who has got a more than 30,000 platelet count and has dropped about from 70 to 50 or 70 to 40, still they will not be a platelet transfused. If it goes down to very low, one may have to rethink about the procedure, or trying to see that why it has caused so much of a drop in the platelet count. Are we extracting too much of a buffy coat, or is that we have probably cut our level a little bit upper rather than lower, so that we will avoid so much of a platelet loss?
Thank you.
Thanks.
Thank you. Couple of more questions from the audience. Can you comment on the use of maternal platelet transfusion for allo cytopenia?
There has been some case reports for that. One can plan to use that, though I would say that I didn't touch upon that because there is no strong recommendation. It is a single center specific, and only in situation if the previous child has developed an intracranial bleed, then there has been recommendation in that. But those are very specific situations, specific cases, rather than considering it as a routine practice.
Thank you. Slightly away question. A patient on anticoagulation develops acute subdural hematoma. After how many days can you restart anticoagulation?
That depends on what is the indication of an anticoagulation. Let us think about a situation. This patient has developed an acute pulmonary embolism, and when you have started them on heparin or a low molecular heparin, he has developed a subdural hemorrhage. So there, both situations are important because this person has got an acute pulmonary embolism. So our cutoff is that we don't discontinue the anticoagulation. We transfuse the patient's platelets, keep the platelet count more than 50,000, and then continue the anticoagulation at the same time. But if think about the same patient who is beyond 4 weeks, so your acute stage is gone, and if at that time he has developed subdural hematoma, then I may be a little bit flexible in cutting down the anticoagulation, looking at the platelet count. That varies with the acuteness, that varies with how big is the bleed, that varies with the acuteness of the clinical scenario.
Thank you. Dr. Tejaswini?
Sir, so if we keep a lower threshold of platelet count, then if there is an acute event and if the relatives are anxious, like how do we convince them? How do we talk to them if something happens?
Yeah, which is not unusual, which sometimes is that the relatives would probably not understand. So it is always important to put all the blames on the blood bank. No, that is a joke. I'm just not saying that the blood bank is not giving us even if I wish to, but I think you may need to talk to them, saying them that all blood products are not same or are not safe. Probably exposing to a platelet count, on one hand, I'm exposing, unless it is absolutely needed, to a risk where those risks. Second thing is that giving a platelet transfusion or a blood transfusion at this time may increase the likelihood of developing antibodies so that your subsequent transfusion will not be effective. And the third thing is, and you can tell them that that is the worldwide recommendation. It is not that you yourself is taking a decision or bypassing the worldwide recommendation. You can tell them, because I know there are a lot of litigations everywhere, but if when you tell them that that is the evidence-based guideline which is worldwide followed, I think they would probably understand that, that it is not your own decision. You are just telling them what is existing.
Thank you. Dr. Deepankar.
Sir, in a case of triple positive antiphospholipid antibody syndrome on a warfarin and aspirin like prophylaxis with severe thrombocytopenia, like 20 to 30,000 or like less than 10,000. So like, should they warrant a platelet transfusion?
Not really, because in an antiphospholipid syndrome, where patient is on anticoagulation because of the primary process, thrombocytopenia there is most likely related to the immune-related mechanism. This patient is not bleeding, and then continuing or giving a platelet transfusion in those situations is not warranted.
Thank you.
Thank you. Dr. Rajat Jain. Unmute, Rajat. Unmute.
Sir, what is your policy of platelet transfusion in dengue, sir? Sir, recently I had a case with in dengue. I usually see that the sir, I'm not able to see. Hello, sir. In dengue, I usually see that when we transfuse the platelets increase. Platelet count of the patient increases. But recently I had a case where the patient he was outside, admitted outside, came to us later. When he was admitted outside, his platelet count was 11,000. He was transfused 1 unit of SDP and 4 RDPs. Still, post transfusion, 12 hours later, his platelet count was only 12,000. So, like when the platelet count is not increasing after platelet transfusion, we think that there is a component of ITP. So, do you think like in dengue, uh, giving the platelet and not increasing, is it okay, or there was a component of ITP in that patient?
And Rajat, I can only say that I'll probably at present will not have an experience because I don't manage any dengue patient here. But from the anecdotal cases or anecdotal experience, I will say that when a patient has received multiple platelet transfusion and platelet count from 11 has gone, it tells that it is a viral induced thrombocytopenia, which is mostly immune mediated. When it is a viral induced thrombocytopenia, which is immune mediated with the adequate megakaryocyte, there is no reason to give him platelet. So we should not react to a number over there, because one has to probably say, by giving even I give another 4 platelets, again the platelet count will be either 12, or it may even go down to 11, or it may be 13. So is there a real justification or a real justification in giving the platelets? I will not.
Okay, sir.
Pankaj.
Sir, I want to know one more thing. When you said that you have to keep platelet count about 10,000, 10,000 will be enough for and safer side for the patient of induction or anything else if patient is not bleeding. If you have those patients who are on S ward, like patient on 10,000 platelet count daily, and you are maintaining them, what investigation you or your resident do regularly for those patients? Yes, clinical examination we will do naturally at, well, whether patient will having gum bleed or a black stool or anything else. But is there any investigations except a manual platelet count, what you will do regularly for that patient to know that yes, the patient has started bleeding or not?
So 2 things. Definitely, as you mentioned, it will be a clinical manifestation, and then to see that if the hemoglobin is dropping, if there is some internal bleeding happening, we are not able to know that. We will not ask for a platelet-specific antibody test or to look at an immune-related mechanism there, because if I am giving that person platelet transfusion, and it finally boils down to the day-to-day variation. If I give a platelet transfusion today, from 10, suppose tomorrow it has been 9. But tomorrow I give him platelet transfusion, from 9 goes to 11 or 12, then that shows that that is just a day-to-day variation. So we normally follow, if at 3 consecutive days, we have given adequate platelet count, in spite of giving adequate platelet transfusion, 3 consecutive days, the platelet remains less than 10, then only we look at some other additional causes. After ruling out, there is no other non-immune causes. And one of the commonest non-immune causes are the different antibiotics. So if there is a likelihood of changing that, because vancomycin is a notorious drug to cause quite a bit of thrombocytopenia. So if there is a possible to change, one may need to look at those before doing that change.
Thank you. Dr. Rajat. Unmute.
Sir, in our institute, like it's a practice. When we do a transplant, especially allogenic stem cell transplant, we when we harvest the donor, after 5 to 6 days of harvesting the donor, we again take the granulocyte from the donor and give it to the patient, because the patient is neutropenic. So I just want to ask you the guidelines, like after how many times one donor of one donor of granulocyte can be like again and again taken for the granulocyte harvest?
Thank you. It is probably a different question from the platelet transfusion, but if I can just say, first thing is that will probably is the institution specific. Granulocyte transfusion, as you know, is not recommended. Granulocyte transfusion can increase the likelihood of a TRALI, and it has been clearly shown that it can increase the pulmonary toxicity, particularly in the allogenic transplant, significantly. So the only evidence-based guideline for a granulocyte transfusion is who has got severe infection, appropriate with a blood culture positivity, appropriate antibiotic therapy for a multiple period is not going to control, and the patient has got an impending chance of improving the counts in the next few days, there it can be recommended. But overall, most of the recommendation is not to give a granulocyte transfusion because of the toxicity associated with that. How, and if you are planning to do, how frequent it can be done, that has not been overall answered, because people do not consider granulocyte transfusion as a standard way of treating. But about 3 to 5 days one may look at. But looking at the platelet count, if your apheresis is causing significant drop in the platelet count.
Thank you. One question from the audience. There's a patient who has got DVT. Patient also has severe thrombocytopenia. Will you put IVC filter in this patient?
That will be definitely is a thought process, because if you think that for some reason, first thing is that you have to probably say why this person got a DVT with a thrombocytopenia, because what is the underlying mechanism? Because thrombosis and thrombocytopenia combination is only one or two things comes into the differential diagnosis. So you may have to look at those causes, trying to see that what is the reason. And if you look at thrombosis and thrombocytopenia combination, because what comes to my mind is one is a PNH, one is a lupus, sometimes a factor V related with the associated other causes of thrombocytopenia. It is not a common thing to have both. So first thing is that identify the reason and then try to monitor that. Second, if it is immune related, giving a platelet transfusion is not useful. But sometimes what happens is that if you're treating someone with some chemotherapy, that person has got an acquired thrombosis related to the elastoraginase or related to the central line, and the patient, because of a chemotherapy, has got low platelet count. There, if it is practically possible to put a filter, that may be thought process, but always with a low platelet count, putting a filter is not a practical use. There you may have to juggle around with your platelet transfusion, low platelet count, and adjust the dose of anticoagulation. So finally, it will boil down to the cause and how long that thrombocytopenia is going to be maintained, trying to see that how that person can be, in that particular clinical scenario, can be appropriately managed.
Thank you. Another question is related to TEG. Do you use TEG to guide you about platelet transfusion in thrombocytopenic patient?
Not really. We don't use the TEG for our regular daily day-to-day practice. That is also not a evidence-based recommendation, excepting if suppose someone is doing a liver transplant, then in the liver transplant with thrombocytopenia, then there is a role for a TEG, trying to see that how. But for a regular practice, for a regular day-to-day practice, we never ask for a TEG or any other parameters.
Dr. Deepankar.
So what is the role of immature platelet fraction in like differentiating ITP versus other causes of thrombocytopenia? And so like immature platelet fraction, if normal, does it rule out ITP? And the second part of this is like immature platelet. Can it be used as a marker if it is normal, thinking it to be a myelosuppression rather than increase, which is mostly dictating towards a increased destruction? So does this dictate into platelet transfusion levels? Like if it is less than 10,000 with normal IPF, should we transfuse? Or like if it is less than 10,000 with increased IPF, we should not transfuse?
Not really, Dr. Deepankar, because I think there are few papers on that, few centers, individual centers may try to look at that. That will be center specific. There is no strong recommendation to say that based on the immature platelet fraction, one can modify their clinical judgment, or one can say that because if this is high or low, that is correlated with the cause of thrombocytopenia. That is a research question. I know that there are papers on that, but it is not strongly proven.
Thank you, sir.
Thank you. Another question from audience is, what is the effect of rheology in circulation? If a patient receives 2 units of packed cells, will it affect the platelet function?
I think that is definitely a good question. There is definitely a correlation between a rheology along with the platelet function. For that reason, initially when I answered that question regarding aplastic anemia, that boils down to how much hemoglobin do you want to push for. Suppose a person has got a hemoglobin of a 90 and a platelet count of 10. 10 means I'm talking about 10,000, and 90 means hemoglobin of a 9. And if you plan to give 2 units of blood to that person and push that hemoglobin to 11 with a platelet count of 10, that will definitely affect the rheology. But think about the same person who has got a hemoglobin of a 70 or a 7. You are trying to give a unit of or 2 units of blood to push that hemoglobin to 8. Then with a low platelet count, it is not going to affect. So finally, it boils down to how is the viscosity of a blood vessel is going to be maintained? What is the PCV you are trying to push with a low platelet count, and whether the body will be able to manage it.
Thank you. There are some questions related to portal hypertension, chronic liver disease, hypersplenism causing thrombocytopenia. If such patient requires surgery and you know that platelet transfusion will not work, how do you manage them?
We usually take them directly for the procedure if it is required, but perioperatively they get a transfusion just to maintain the hemostatic during that period, and we add them tranexamic acid if they don't have any previous episode of thrombosis. If a likelihood of a bleed is there, if it is available, someone may use a recombinant factor 7A, but that is not always practically possible.
Similar question is about refractory ITP with platelet count below 5,000 going for splenectomy. No clinical treatment has worked so far. What do you do?
You have to talk to your anesthetist. Anesthetists need to get convinced. Sometimes the surgeons get convinced, but not the anesthetist, that a transfusion of a platelet count is not necessary. What is practically done, and that is probably rather than fighting with your surgeons or anesthetists or the OR staff. So during perioperatively, you can just transfuse platelet, because as soon as they clamp the splint pedicle, the platelet count immediately improves. It is not again evidence-based to transfuse platelet perioperatively, but sometimes it is not the best of the real world where all of us will wish to live. So sometimes rather than the fighting, perioperatively transfusing and the pedicle as it is clamped, things should be okay.
Thank you. Why is the threshold of platelet count different for lumbar puncture and for epidural anesthesia?
Yeah, so they think the overall it finally boils down to that you are infusing something to the space, and the second thing is that they say whenever you are doing the LP with the type of a needle what you are using, even if it varies from epidural. Sometimes it is when they talk of epidural anesthesia, they don't talk of only epidural anesthesia, they talk of epidural catheter, because sometimes they plan to put a catheter over there. So that is the reason why the threshold they try to put a little bit higher rather than the lumbar puncture.
Last question here is, what is the role of platelet function test or CYP genotyping based strategies for platelet transfusion in a patient on DAPT going for cardiac or neurosurgery?
I am not aware about that, and probably my knowledge about in that aspect is pretty limited. but whenever I have looked at least the other guidelines, they do not recommend about this specific thing. And so doing a platelet function test, I do not think will be necessary.
Right. So I think we have answered all the questions from the audience. Faculty here, if you are left with any problem? None. Then Dr. Oro, thank you so much. Great.
Thank you, sir.
2 hours of continuous talking, lecture, and answering all the questions. Many of them were very interesting and difficult questions, and you have handled them very aptly. Over 400 people have logged in from various countries, almost 11 to 12 countries, and half of them are fellows and trainees. They all have benefited, and I think the care of patient will be much superior after this talk.
Thank you, sir. Thank you very much. I really appreciate.
Thanks all for making this session.
And all of you have a wonderful weekend.
Thanks to Intas for supporting us, and thanks to Mice Ideas for managing the show. So good day to Oro and good night to all of you. Have a wonderful dinner with your family.
Thank you, sir.
See you tomorrow morning. Bye-bye.
Regards. Bye.
Good night, everybody.